Glucocorticoid deficiency frequently leads to hypoglycemia because of the disinhibited glycolysis and reduced gluconeogenesis. Now, you must remember that this is specifically seen in secondary deficiency of adrenocorticoid hormones due to the pituitary insufficiency because it is associated with the decreased somatotropin secretion, the hyperglycemic effect of which will be absent. Basically, the hyperglycemic effect of the somatotropin is absent over here. Now, you can trace out that the hypoglycemia activates the sympathetic nervous system in return and inhibits the release of insulin. And thus also it influences the lipolysis and the protein breakdown. The reduced lipolytic and proteolytic action of the cortisol is more than compensated by a decrease in the insulin and increase in the epinephrine effect. Lipolysis and protein breakdown are thus stimulated. Further effects of the raised epinephrine release are tachycardia and sweating. The reduced sensitivity to catecholamines on the heart and the blood vessel leads to a fall in the blood pressure despite the release of epinephrine. There are other mechanisms to this fall as well, which I'll be highlighting later on. Now let us move on to the GI disturbances. They occur primarily due to the reason that there is a diminished secretion of hydrochloric acid. So the pathogens that have been swallowed will be less effectively killed in the stomach. And more commonly, it can cause the gastrointestinal infections. Diarrhea and vomiting occurs with the corresponding loss of water and electrolytes from the body. The lack in the glucocorticoid effect on the blood-forming cells results in anemia, that is the decreased hemoglobin concentrations, neutropenia, that is the neutrophil levels or the neutrophil count is going to be decreased. Then we have eosinophilia, where the eosinophil count is increased, and lymphocytosis, where the lymphocytes are increasing in number. Other symptoms would include fatigue and weakness. Furthermore, depression is also seen in these patients, which is caused by the lack of glucocorticoid action on the brain. However, do remember that there is a window period in which the symptoms are masked since the cortisol sensitivity is increased in the target cells. Let us move on to this another important symptom, that is the darkening of the skin. What is happening is that the decreased levels of the cortisol leads to increased levels of a precursor hormone, pro-opiomelanocortin hormone, which in turn will increase the ACTH levels, as well as the melanocyte-stimulating hormone. And thus, the melanocortic effect is seen, which is noticed by the darkening of the skin. And that is why the name bronze disease is given to it. As you may recall, we even discussed it in our case study that the patient was suffering from hyperpigmented patches specifically on the arms and the legs. So you have to notice these things while diagnosing Addison's disease in a patient. The retention of potassium, magnesium, and hydrogen leads to reduced neuromuscular excitability, as well as abnormalities of action potential formation and the conduction in the heart due to hyperkalemia, hypermagnesemia, and acidosis. Sodium excretion, on the other hand, causes hypotension in the patients. Lastly, let us discuss the effects of deficiency in androgens, which is manifested as sparse pubic hair, decreased libido, which is the decreased sexual drive. But remember, these are masked in males if testosterone production is normal in the males. Acute worsening of the symptoms leads to an emergency, which is known as Addisonian crisis, with extreme weakness, fall in the blood pressure, tachycardia, that is the increase in the heart rate, diarrhea, hypoglycemia, hyponatremia, hyperkalemia, and oliguria, that is a decrease in the urine excretion.